Hello, good morning, everybody, and thanks so much for joining us for this fourth webinar in our six-part GP webinar service. So today's event is an hour-long Q&A with members of the Anxiety Disorder Service team at St. Patrick's Mental Health Services. And on the panel today, we have Dr. Michael McDonough, who is Consultant Psychiatrist and Head of the Anxiety Programme, and Dr. Anne Rakpraja, who is Psychiatrist Registrar on the Anxiety Programme. We only have an hour and we obviously want to get through as many questions as possible and make this as practically useful to everybody as we can. So I'll just front load the housekeeping now and get through a few little bits and then we'll kick off. So just to say, the anxiety team will be answering questions under four main themes today: an overview of the Anxiety Disorder Service, responding to anxiety presentations in the GP surgery and when to refer, the impact of COVID-19 on anxiety, and therapies for anxiety disorders. Now, we want all of you attendees to really drive the event as much as possible and get involved and ask your questions. So feel free to submit any questions you have using the Q&A function below there on your screen. And we'll try and get through as many as we possibly can. I'm sure there'll be a lot of common themes that will emerge, and hopefully we'll get to answer all of your questions. The other thing to say is the ICGP CPD certificates will automatically be sent out to you within the next 2 weeks. That's to any GP who has registered and is attending live today. And as I mentioned, this is the fourth in the series of the GP webinars, and we have previous ones on older adult mental health, adolescent mental health, and self-harm, and they will all be made available on the St. Patrick's GP portal over the coming weeks. If you've missed any of them, you'll be able to catch up there. So before I introduce the panel, just one other thing to note: the Anxiety Disorder Service at St. Patrick's Mental Health Services caters for adults over the age of 18. Now, anxiety services for adolescents are provided for within our Willow Grove Adolescent Unit and Community Dean clinics. So if you have questions today regarding treatment or referrals for adolescent services, you can drop an email to communications@stpatsmail.com. That's communications@stpatsmail.com, and the team there will pass on your query to a relevant staff member who liaise with you on that. So that's all the housekeeping done. So we'll kick on and I'll welcome our panelists. We'll begin with Dr. Michael McDonough and Dr. Anne Rakpraja. Good morning, Michael and Anne.
Good morning.
Good morning, Jan. Thanks very much.
Not at all. So we're going to begin. We're going to use this poll functionality occasionally this morning because it just gives us a sense of how people are feeling about things or how common certain presentations are. So I'd ask you, please, if you could engage with us on this first
Good morning,
poll.
everyone.
Yes, good morning to everyone. On this poll, that would be great. So really the first question is, where do you as a GP feel most challenged when managing anxiety disorders in primary care? Is it assessing an anxiety disorder, treating an anxiety disorder, managing the disorder prior to referral, or accessing specialist services and knowing when to refer? If you could click on one of those, that would be great, because it'll just give us a sense of where the majority of the people joining us this morning, where you feel the biggest challenges are, and then we can maybe weight questions in that direction. So if you'd like to vote there, and just to underscore, the voting is completely anonymized. We can't see who's voting what or choosing what, so feel free to select whichever one you like. So while you're doing that, we'll get started with our first area that we're going to be discussing, which is an overview of the anxiety service at St. Patrick's. So Michael, I wonder, could you just give us a sense of what forms of anxiety the service treats?
Yes, so there's a general referral system. So the hospital accepts general referrals, and there's a prompt assessment of need system that the nurses provide, which gives us a snapshot of each referral. So the cases that we would take on, that I would select for assessment, would be cases of kind of long-standing primary anxiety disorder. So these would be people with kind of lifelong panic agoraphobia, OCD, health anxiety, generalized anxiety, though that can be a little tricky, social anxiety. So an enduring form of anxiety disorder that affects the person's mental health and well-being. Now, quite a few of our referrals would have episodes of depression, sort of secondary depressive crises, and that wouldn't preclude them from being taken on for assessment. What I'd be filtering out in terms of referrals for our services would be cases of agitated depression that might look like a generalized anxiety presentation, but are actually a form of mood disorder. So we might discuss that as we go. And once we assess, then we will refer people on to the anxiety program for group CBT intervention if they're suitable, if they have health insurance in place. So sometimes we can subsidize attendance for very suitable cases, or we can refer for individual CBT, or make advice on medicine alterations or treatments. Some of you may well have referred into us and received the reports back from Anne and the other assessors in the assessment clinic. It'd be good to get some feedback on how helpful those reports are. They're quite detailed. So really, we're looking at taking on people with primary anxiety disorder that are going to be responsive to CBT intervention. Anyone in a very agitated or overwhelmed state, often that's a form of agitated depression, isn't really suitable for CBT intervention. They're not really in a place where they can learn or do the experiential work. So that's an important point. I don't know if you want to speak a little bit, Anne, about the assessment process and how that goes and what we're trying to look for there.
Yes, well, basically we're trying to get an understanding of the person's day-to-day difficulties and how that's impacted their life. A lot of people with the severe anxiety disorders haven't been able to engage and interact with the world maybe in quite a long time. So not being able to continue with work, not being able to have support from friends and social circles, and sometimes even to the point where they're not able to leave the house at all. So we're just trying to get an understanding of each individual's difficulties and trying to target the therapies that will be most beneficial for each person.
Very good. And I think the real skill there sometimes is assessing the underlying personality. So anxiety disorders will blend with different personality profiles, perfectionistic or anancastic personality, emotionally unstable personality sometimes is mixed in. So as clinicians, we work, and as primary care clinicians, you will constantly be kind of keeping those questions under review. How much of this relates to the underlying personality functioning, how much relates to mood, how much relates to a primary anxiety disorder. So we're happy and very much eager to kind of help with that process of assessment and balancing out. And you might notice some of our assessments are actually referred on for long-term psychotherapy if there's underlying traumas. So it isn't necessarily a case of just referring on to group programs. And there are also kind of rating scales that we use that you'll see in the reports that are a way of kind of grading the presentation, which can be useful in terms of outcome measurement, etc.
I'm conscious there are some of the challenges that you noted there, Michael, around assessing an anxiety disorder. And just quickly to return to that poll, I'd be interested to see if that's one of the areas that the people joining us this morning find to be one of the biggest challenges. And actually, it's sort of on a par with managing an anxiety disorder prior to referral. The overwhelming biggest challenge seems to be accessing specialist services and knowing when to refer. So 71% of you joining us today feel like that is the biggest challenge. And that's the next one, which is a long way off at 29%, is treating an anxiety disorder. So I suppose related to accessing special services and knowing when to refer, a key question might be, how long are the waiting lists for either inpatient or outpatient treatment? If GPs are looking to refer, like, will their patients have a long wait before they be able to access services?
So assessing the kind of outpatient assessment, we can normally turn around within, for those that are suitable, within a few months. There's a maybe 3, 4, 5 month wait. Melissa, the team secretary, is brilliant at slotting in cases, deserving cases that might need to jump the queue or whatever. But generally speaking, as I've said earlier, these are enduring cases of anxiety disorder. There isn't generally an emergency involved in assessment. I think accessing, kind of promptly accessing services is often for inpatient admission. So somebody, let's say with OCD or panic agoraphobia who's become housebound, maybe they have a secondary depression mixed in, and how do you get them, you know, into a service where they can be acutely treated. And our inpatient service will normally admit people within a week or two. We often time admissions just prior to the next cycle of the program, so that can delay things, but usually there's pretty quick turnaround in accessing inpatient care in our service. But of course, health insurance is required, so that's obviously an important filter. Accessing care for those without health insurance, I think, is still something we maybe might discuss. Knowing the high quality CBT therapists around working privately that patients can access is something we might have a think about. But obviously a lot of it involves, for those more urgent cases, involves judicious kind of drug treatments, benzodiazepine drugs, or antipsychotic medicines like olanzapine for sleep to help with agitation, as well as commencing an SSRI or an SNRI, which will take a few weeks to work. And I think that might be an important discussion point, how to manage an acute presentation while you're accessing specialist services. Happy to discuss that. I think there's one question there, Jan, is there?
There is, yeah. I think it's got to do with just the massive increase in levels of anxiety that people have been noticing over the last while, which we'll come on to when we're discussing, you know, the events really of the last 18 months and the impact that's had on people. I just, for the moment, while we're talking about the anxiety service, and we will get on to talk about, as you all sort of indicated in that poll, about the issue of knowing when to refer, which we'll get on to now shortly. But just, I'm interested what programs are actually for anxiety are available within St. Patrick's.
So we've got the anxiety disorders program. So it's called the anxiety disorders program rather than the anxiety program. So anxiety can present, anxiety is an experience, not a diagnosis. So there's lots and lots of presentations where anxiety is prominent, but it isn't an anxiety disorder. So perfectionistic individuals or people with, you know, unstable emotional attachments can have a lot of anxiety, fears of abandonment or whatever. So anxiety and it's also a very prominent feature of agitated depression. So again, assessment is important. So the anxiety disorders program runs over 3 levels, level 1, 2, and 3. Level 1 is 3 days a week for 5 weeks, quite an intensive group program, good at delivering experiential, behaviorally focused cognitive therapy according to the protocols for each anxiety disorder, which we can go into if need be. We get pretty good results. Our results are published and audited. There's level 2 also for people with more kind of core psychological issues connected with their anxiety. And then level 3 is the follow-on group process. So that's for people with primary anxiety disorder. And usually we have 20 patients in each cycle of level 1. So it's quite a busy program. It's never empty. Each cycle fills up. But there are other programs available for people who don't have a primary anxiety disorder, but may have high levels of anxiety connected with another problem. So I'm a big fan of the acceptance and commitment therapy program run out in St. Edmundsbury by Aisling Curtin and her team. That's an excellent program for people who want to learn how to live according to healthy values in a stress-free way as you can. So living according to healthy values in a mindful way is the core of that program. That can be very useful for people where anxiety is linked with underlying kind of difficulties with a lack of self-compassion or very rigid or perfectionistic approaches to things. The COVID crisis, I think, brings out these sort of difficulties in coping. Anyone who struggles with coping with uncertainty or change is going to struggle at the moment, as we all have over the last year or two. And programs like the ACT program are a very good option for that. And obviously there are other programs run through the psychology department, like the compassion focused therapy program or the radical openness program or the living through distress program, which are skills based around particular presentations, be it emotional over-control or dysregulated emotions or a lack of self-compassion. The CFT program actually is heavily subscribed. There's also a compassion focused therapy program for eating disorders. So when we make an assessment, we might refer people across to one of these other programs apart from the anxiety program if the anxiety is linked with a different difficulty from a primary anxiety disorder.
I'd just like to skip on to that point that was raised in the poll about this, challenge around knowing when to refer. And you mentioned how so many of these conditions are enduring and they've lasted for a long time. So I'm sure there's not a sort of top 3 things to notice when to refer, but could you illuminate for us when some of the challenges around when to refer and what you could advise some of our participants around that?
Yeah, I think if somebody has their OCD since their teens and they've engaged with a CBT therapist locally and have done pretty well and have managed to contain their symptoms quite well and have a reasonably good quality of life, maybe you've commenced an SSRI medicine to treat any comorbid low mood symptoms or mood depletion, and they've responded quite well to that, and they're on maintenance treatment of the SSRI, which you renew every 6 months. We don't need to necessarily take on a referral like that if the quality of life is good and the condition isn't impacting. But if somebody's having ongoing dysfunction, they're making choices in their lives that are being affected by anxiety. They're avoiding long-term relationships or promotion or whatever, as you'll often see with anxiety disorders, it pushes people off course from their natural trajectory in life. Then that the evidence would be strongly in support of getting kind of more intensive specialized inputs to try and diminish the burden of anxiety disorder so that the person can progress in life as naturally as possible and fulfill their potential. So there's a pretty low threshold for referring cases of primary anxiety, enduring primary anxiety disorder. If the person's been held back in life, we're happy to assess them, review them. They're not your acute cases, and there may not be the cases that are giving you the biggest headache from in your day-to-day work, but they actually will do well within our service. The other mode of referral is somebody who presents in crisis. Let's say somebody with OCD who's suddenly gone into crisis over the COVID period, and we've, as Anne will know, had lots of referrals like that. If they're acutely distressed, can't function, overwhelmed, then by all means refer them in for admission, and a prompt assessment of needs with a nurse can also occur. But I'd have a low threshold for referring for admission somebody who's in acute crisis, who has a history of long-standing anxiety disorder, but now is in a depressive crisis. We're more than happy to take on cases like that, and they generally do excellently well with restoration of mood and then the program. So yeah, I think it's those 2 categories: somebody presenting in crisis, but I think it's important, if somebody does present in crisis, to commence an SSRI or an SNRI, as most of you will do, not to hold back on that if there are any markers of mood depletion. And you might speak a little bit about the tricks for spotting mood depletion or secondary depression in cases of, let's say, generalized anxiety disorder. It can be a tricky read, can't it? Do you want to speak on that for a moment, Anne?
Yes. So we would be looking for biological markers, sleep disturbance, particularly middle insomnia or early morning waking, diurnal variation, where somebody may wake up in the morning and it's just very difficult for them to face the day. But that may get a little bit easier as the day goes on, and they may be able to get a few more things done by late afternoon, evening. Loss of appetite, particularly if there's been weight loss, low energy, difficulty with concentration would be an important sign as somebody who might be psychomotorly retarded, or they will have difficulties with concentration. But also, some of the just more obvious things of lack of interest. They used to have lots of hobbies and meet other people socially, and they no longer have any interest or motivation to do so. And sometimes people may come in and not describe it, or they say they don't feel depressed, and it looks more, they talk about their anxiety, but if the biological markers are there, then most likely it is a more of an agitated depression type picture.
How well does that respond to SSRIs or SNRIs, do you think?
Very well.
Yeah, they do brilliantly well, people with that kind of presentation. So a typical story is, let's take GAD, which is the trickiest of them. Somebody who's had a long history of worrying about any uncertainty in the future. Okay, that's at the heart of generalized anxiety disorder, which is really a disorder of worry, excessive worry. So these are individuals who look to the future, spot any area of uncertainty, and worry about trying to problem solve hypothetical issues before they occur, and they exhaust themselves. So you will see someone with GAD might have trouble initiating sleep. They might get stressed or anxious late in the evening when things are quiet and they've settled down after their day's activities. But they wake up the next morning and they've got energy and they keep going. Well, when GAD turns into depression, the initial insomnia starts to become early morning awakening, and the mornings start to become worse. The person wakes up with anxiety and agitation before they have a chance to worry. It's like a biological kind of wake-up call in the morning, a sign that the mood has become depleted. If you see that pattern along with a kind of an episodic kind of deterioration in mood, so you look, as Anne says, you're looking for, like, depressive episodes are episodic, whereas anxiety disorders are chronic and long-term. So what you're looking for is that shift from baseline towards a depressive picture, commencing a long-acting benzodiazepine in the morning, like clonazepam, commencing an SSRI or an SNRI, and maybe even a medicine at night that's going to help with agitation and sleep and appetite, like low-dose olanzapine, 2.5 milligrams. That can make a big difference in the short term, and several weeks later when the SSRI or the SNRI starts to work. I find that if SSRIs aren't effective for that agitated depressive presentation, SNRIs, particularly high-dose venlafaxine, can be really helpful in turning things around. And by all means, press ahead with a switch to venlafaxine if an SSRI has had partial impact. At that point, of course, you may well have referred on to us and we may well have reviewed and accepted the case. I think there was a question there, Jan, was there?
Yes, there was. We're just moving on to COVID-19 and anxiety now. Just to reassure people, we're kind of skipping through these topics, but feel free to send through your questions and we can revisit any aspect. One of the questions that had come in was around the massive increase in anxiety over the last year or so, and an observation by this participant this morning that most patients didn't want to necessarily be counselled, but this attendee was saying that they found the Lundbeck questionnaire very helpful in terms of helping them assess what was sitting in front of them in terms of the patient that had come in. So I don't know, is that a questionnaire you'd like to comment on, or that you also?
I'm not familiar with the Lundbeck questionnaire. Is that a Lundbeck questionnaire, BMJ? Okay, very good. Yeah, I'm not familiar with that. It's not one of the ones we use. We use a kind of more disorder specific questionnaires. Our general outcome questionnaires would be the BAI and the BDI, Beck Depression Inventory, Beck Anxiety Inventory, and there's a work and social functioning scale that we use, but I don't know the Lundbeck scale. If whoever Dr. Fabian wants to come on and describe it to me, that would be great.
Give a bit more info.
Yeah.
And just, it's interesting, that observation that most patients don't want to be counselled. You know, I mean, are there any sort of ways in to try and reassure people, or is it just literally maintaining communication and trying to reassure and trying to, you know, perhaps after a prescription of some kind that, you know, they might become more open to that option?
Well, I think, you know, counselling isn't essential. I think it's, you know, that providing emotional support, understanding a safe space to discuss stuff isn't needed for everyone. It isn't certainly needed for anyone who feels emotionally vulnerable and needs that human support and maybe isn't getting it in their lives or didn't have it in their development as a child. So that would be a big part of what humanistic and integrative counsellors and psychotherapists would do. But really, if somebody presents with a clinical disorder like panic agoraphobia or secondary depression from GAD or whatever, I think it's a case of saying, well, there's a clinical treatment for this that will work. This isn't about counseling. This is about a therapeutic intervention with a beginning and an end and a target. And I think that can be useful in informing people about what's going to happen here. It's different from referring somebody for humanistic and integrative psychotherapy to explore complexities around the formation of their personality and adversities that have occurred over their lives or early life traumas. That's a completely different thing, and it's a much more of a long-term project and a voyage of exploration, and and it's something not to enter into lightly. Whereas if you've got panic agoraphobia and you can't get to college, that needs treatment, that will respond to treatment. We would have Through our video delivered anxiety program, we'd have patients at home who can't get to the shops, and they're working on daily targets and tasks for that. And that kind of practical focus is very much what we're about.
Just as we move on to discussing things around the pandemic a bit more specifically, I just think it's probably important to acknowledge that everybody attending today, I can imagine your anxiety has been peaked yourselves over the last year or so. Anybody working on the front line has seen a major surge in just what is expected of them, and I'm sure in the anxiety of their patients. So you might just indulge us on another poll, if you wouldn't mind, which is basically just to ask, you know, have you experienced heightened anxiety in the past 12 months during the pandemic? I'd be interested to see, you know, what people's response to that is. I've an inkling of what it might be, but if you tell us, you know. And while you're doing that, we'll just move on to discuss really, you know, how has COVID-19 impacted anxiety disorder presentations?
Super, yes. Dr. Fabian has responded to say he'll send on the questionnaire, 33 questions. Great, Dr. Fabian, thank you. I'm learning something here. Be good to look over that, and if that's used in primary care, it'd be really good for me to have a view on it or a knowledge of it. So, Anne, which anxiety disorders have we seen most of? What presentations have escalated over the COVID period, do you think, within our service?
A few. I mean, there would be the obvious OCD with contamination fears, but even things like health anxiety, which is a subset of OCD, generalized anxiety disorder due to the uncertainty and worry about what's going to happen. The folks with panic agoraphobia or social anxiety that have difficulty leaving the home or interacting with others, they've probably appreciated COVID and not having to try and get out there. But in the long term, that's reinforcing, you know, some of the dysfunctional aspects in their lives. So we actually, you know, want to get them out of their comfort zone that they have fallen back into. I would say so. Those are some of the more common ones.
Yeah, brilliant. So that's the paradox in that some anxiety disorders have done. You know, people are reporting life's easier. If I've got social anxiety, it's much easier for me not to go to college because I can do everything by video. I've got panic agoraphobia. It's easier for me because I don't have to go out and about. There are restrictions. There's a 5-kilometer limit I can travel, and that suits some people. And it's been interesting in that some people have felt more normalized within society in the lockdown, which I think is an interesting side note. But really, quite a lot of people have been made ill by COVID, and not just by the virus. People with a worry tendency, people who struggle with change, people with fear of contamination. The fear of, you know, in OCD, the fear isn't of the person themselves getting the infection. Usually it's of spreading it to others and being responsible for harm. So that's crucial. So helping people with that contamination-based COVID fear is about encouraging them to work within the guidelines, but not to exceed them. So you don't have to sanitize your hand every time you pass a squidgy machine. You don't have to wash your hands excessively. Just work within the guidelines, wear the mask in the shop, but not everywhere else. So encouraging people to be more relaxed to follow the guidance, but only the guidance and not exceed it. That's been a focus. And we've had a fair degree of success in that. So remember, obsessive compulsive disorder is a disordered. It's a disordered relationship with risk. It's not healthy. It overestimates things and it engages in behaviors that are excessive. So it's about finding that sweet spot where things are kept safe without being excessive.
You mentioned a little while ago, Michael, about communicating with people through video link, and I'm conscious that, you know, there is a sort of a home care package is maybe one of the ways that service delivery has changed around anxiety disorders. Maybe you could talk a little bit about how the service delivery has changed over the last year or so.
Yeah, I think credit to our managers, I think, who worked really quickly to convert almost our entire service to video delivered care within a few weeks. via Microsoft Teams rather than the Zoom platform. So Teams is felt to be quite secure, and I do my ward rounds by Microsoft Teams. We deliver groups on the anxiety program via Teams. It took a while to get used to it, but it works quite well. So we have individuals sitting in the groups in different rooms around the country. On Action Day, which is the Tuesday on the program, which is when people will go out and do behavioral experiments, they can take their phone with them and be in the group as they're having a panic a few miles away from home and get live guidance on the behavioral experiments they might do or whatever. So I think it's added a lot of richness and new kind of layers to the work. And the outcomes from last year were audited there, as we do every year, and the results are the same as every other year, which are good with high impacts, except for one condition. I wonder if can anyone think what condition hasn't done as well with video delivered care during COVID? Any guesses on that?
The question and answer box has gone very quiet now that you've asked the question.
I'm sure there's lots of people guessing correctly, but it's actually social anxiety disorder. So live face-to-face interactions are important to treat social anxiety disorder, to overcome the anxieties and the safety behaviors and so on. The social anxiety component haven't done quite as well. Now, we don't know if that's because of the lockdown or is that because of the video delivered care. We're going to get a new set of results for this year, and we can observe whether the easing of the lockdown has had any impact. But that's the only condition that hasn't done quite as well, the social anxiety component. That said, we still are taking people with social anxiety onto the program. But it's been amazing. I think in what we'll probably do is continue to deliver the anxiety program by video in a hybrid fashion. So some of it will be face-to-face and some of it will be by video, where we might alternate them.
It's one of the great ironies about the last year, and particularly around so many of the treatments for anxiety can focus on opening up your world, expanding your world, growing your world. And so much of the messaging over the last year or so has been stay at home, shrink your world, see less people. It's I'm sure some people who, I think you mentioned it earlier, some people who had managed quite well over the years with their anxiety might be having sort of relapses, if that's even the term, a re-emergence of some of their symptoms over the last while.
No, I would definitely agree. I mean, obviously the pandemic has been something in modern, I mean, we've gone through pandemics before, but certainly in the last, 50 years or so, the rate that it spread globally, just because we are more international at this point, it has really scared a lot of people, just to put it in those kind of frank terms, and that there is a lot of uncertainty for a lot of people.
And is it a thing, I know we were talking about, this idea that maybe somebody who has enduring or long-term anxiety or anxiety disorders related specifically to COVID, like, is there a sort of a latency in people that can nearly be activated by an event like this, that people will experience levels of anxiety around this experience, but that they may not need to worry about it into the future?
Yeah, I think, I mean, as human beings, we're programmed to respond to adversity, aren't we? I mean, we're programmed to deal with adversity in different ways, and the anxiety system, the paranoia system, the mood system are meant to be triggered by novel and challenging circumstances. But triggered in a way that helps rather than in a way that holds things back. So I think there's been a lot of excellent coping out there. A lot of people are doing very well. I think as a nation, we've been quite adaptive. Certainly the economy has done better in Ireland than in many other countries, I gather. So I think there's been a lot of good stuff that's happened, a lot of getting back to basics, a lot of families connecting again, a lot of good coping out there. I suppose it's the dysfunctional coping that we would see, which is the individual who doesn't cope with change or uncertainty too well. Maybe the individual who's been maintaining equilibrium by working really hard and staying in control of stuff, and society has been predictable and manageable, and they've been just fine and high achieving, and suddenly they can't control things as much as usual, and that leads to an incremental depletion and a sense of being overwhelmed. So we've certainly seen that, but I think it's more rich than that. You know, it's about family conflicts that have arisen in COVID times. It's about worry about parents being exposed to the condition or getting ill with it, and that bringing up kind of old family and relationship issues and so on. Worries about finance, that kind of thing. I think it's not necessarily all just directly related to a fear of COVID and what it might do. It's been the sort of the societal shifts that have come with it that some people have struggled to cope with, I think. But I think it's particularly, I suppose, we're highlighting individuals for whom change and novelty isn't a pleasant thing. People who don't thrive in those circumstances. And I think programs like the Acceptance and Commitment Therapy program are brilliant for encouraging people to sit back and think, well, what are healthy values for living, and how can I make the best of this circumstances in line with my values or towards my values in a mindful way. And that's the key to coping, I think, in adversity or in novel kind of challenging situations.
We might just have a quick look at the results of that poll when we were asking our attendees this morning if they'd experienced, and well, unsurprisingly, 86% of people have experienced heightened anxiety in the past 12 months, with just 14% not having experienced heightened anxiety. Just on that note, I wonder, you know, are there any sort of strategies maybe that you could advise GPs to use around self-care or prioritizing self-care to assist with this, or just any sort of advice to help people manage their own heightened anxiety if it's not something that they're used to dealing with themselves in a professional capacity?
Yeah, gosh, yeah, coping with sort of occupational anxiety. I don't know. I think the GPs might be better at advising me than I them. You know, I think GPs are an amazing group in how adaptable they are and how much they can manage and the complexity they deal with and the common sense they have to apply on a daily basis. So, you know, obviously, if anyone is suffering with a pattern of anxiety, that's in keeping with sort of disordered level of anxiety, then it's important to get that help. We know doctors are very poor at accessing help and treatment when they need it. So I think if there's a clinical level there, get that looked into and get that assessed and treated either with a colleague or attend one you know, our service or any service. We're more than happy to look after you, and many doctors we've looked after over the years. But if it's more generally kind of tips for managing, I mean, it's the usual stuff, I suppose, about scheduling things in a way that's manageable, to make sure your clinics are manageable, make sure you get your breaks, don't overdo the kind of paperwork and be overly meticulous in things. Obviously, there's a level of rigor required, but excessive meticulousness is probably wasted energy. So some of, you know, those that end up in a medical career are often quite conscientious and diligent individuals, and sometimes we can have too much of those traits. So I think being able to be flexible, adaptable, and let go of things if you've done enough, I think is important. And to make sure you get your downtime in the evening and a good night's sleep. Sleep is so vital, isn't it? Yeah. And exercise and supportive colleagues. I mean, I think for a GP, chatting with a like-minded colleague and having a supportive chat with them is going to be worth its weight in gold, better than any discussion with any counsellor or therapist. Talking with someone that you share an experience with and getting tips and so on is important. Dr.
Fabian has come to the rescue again with more useful information to tell us that the ICGP run a wellbeing webinar for GPs. So if it is a thing that's been part of your experience over the last 12 months, maybe that's something to engage with. And I'm sure there's a lot of useful strategies and advice in that also. We're going to move on now to talking about, although actually, sorry, I just see one question related to COVID there from Mark. Wondering, can you see a glimmer of hope for some post-traumatic growth for patients and everyone when this pandemic settles down?
Anne, do you want to answer that one? Seems a bit difficult for me.
No, definitely. I think that, as Dr. McDonough has said, that there have been a lot of strengths that have re-emerged, that, or maybe not re-emerged, but that have been recognized the lasting impacts of of COVID on mental health, you know, we'll have to see as we come out of lockdown how that affects things. You know, there will be people that are anxious that we are coming out of lockdown. But overall, I think to have, despite all the losses that we have gone through and that people have suffered, that there is a lot of hope. And certainly that if the anxiety has grown to a point where it is disordered and disrupting life and disrupting functioning, then there's the anxiety disorder specialty clinic at PAS. Yeah,
I mean, I think one of the messages we return to time and again in the program is adversity is an opportunity for learning, as long as it doesn't overwhelm us. So there's huge learning in adversity for us individually and collectively. And the program is very much around experiential learning. So this isn't just learning from a book, it's about going out and finding out, will you collapse if you have a panic 2 miles away from home? Will you actually collapse? Is the dizziness you experience the kind of dizziness you can faint from? Well, let's do an experiment to find out. Or if you go into the supermarket and don't wash your hands excessively afterwards, just do it once, will you catch COVID and spread it to your family? You know, these are experiential learning tasks that are very difficult and challenging, but done in a way to help people develop resilience and develop a truer picture of the world around them, a more confident view of themselves and the world around them, without being naive either. So I think having come through the adversity of all of this, there will be plenty of dividends, I think, in lots of areas. Obviously a lot of loss and a lot of upset, but certainly there'll be learning in it for us all and nationally too, I'm sure, particularly with the video delivered care. I think is going to stick with us and I think be a new string to our bow.
There's a question in here, you slightly touched on it earlier, but I'll just ask it in case you've something additional to add. Siobhan was wondering, you know, why would someone that has worked on their full potential, have what they want in life, everything seems to be going fine, then fall apart during COVID? If they'd gotten to that place, like what, you know, is there I'm not sure, Siobhan, if you mean, you know, what is it about something like a pandemic that would sort of trigger that kind of response when everything else, all other sort of metrics in life seem to be fine?
Yeah, I think usually a cognitive therapist would say that is as a result of breaching dysfunctional rules or rigid rules. So you can be high achieving and have a great family life, have a great working life, you know, go for your 5-mile run every morning, be super fit, have a great diet. But if you're doing all of this with a rule in the background that says you must be doing it all and it must all be going perfectly well for you to be acceptable, for your life to be acceptable and good enough. If there's a background inner criticism behind all of that success, and you can no longer succeed on a daily and weekly basis as you normally would because of COVID restrictions, then that critical voice is going to become more active, more aggressive, and eventually will drag you down. And what people will do is try and find ways of coping that involve trying harder rather than giving themselves a break. And it's that trying harder that leads to mood depletion and further agitation, deterioration, and people will present in a crisis. So the focus increasingly is on transdiagnostic kind of supports like the compassion focused therapy program, like the ACT program, to help people look at their values for living, look at, you know, the internal dynamics that might be a little toxic for them, because they will be exposed at times of adversity. And, you know, it's a very good question. And I'm not saying what I've said is the definitive answer, but it's certainly, you know, for any one individual, it's a case of working out how this has happened. You know, if something happens unexpectedly, there'll be a reason for it. It's a case of trying to get at that reason and that kind of that process, that causation. It's a big part of what we do as a team, is trying to piece together these kind of stories and understand better how to protect people going forward.
And it's confronting for any of us to realize that we can't outmaneuver global disaster. That part of being a human is things happen and we can't always plan for it, control it, outmaneuver, do all the good things that we were taught to do, and that everything will be fine. And I think that sort of speaks back to, I think it was Mark's question about the opportunity for post-traumatic growth, even realizing that yes, sometimes I can't plan for this stuff, but I can weather it and come out the other side and, you know, continue on. The whole maxim of this too shall pass, which I think was probably cited more than any other phrase over the last 18 months, but it's true, you know. We might move on to therapies for anxiety disorders, and we were talking about it on and off throughout the morning about OCD, and if we could maybe discuss a little bit about some of the treatments that are available for OCD.
Right, Anne, do you want to take that one?
Well, as Dr. McDonough had mentioned previously, there is the anxiety disorder program, which is delivered in a group format. And people actually really do very well in the program because there is a sense of camaraderie between participants. You know, for some people, they have thought that nobody else suffers like this, or nobody else is crazy like I am, you know, those kind of thoughts. And, you know, they find that, oh, you know, we're all different in many ways, but there are some common themes that we deal with in our lives. And so there can be great learning from each other. We also do offer individual CBT sessions, which often go hand in hand to help support the group sessions. And then we definitely would consider medications. As Dr. McDonough said, it'd be very important to replenish the mood. Otherwise, somebody may not be able to engage in the psychotherapeutic inputs. So we would take a look at a combined approach, and then also involve the other members of our multidisciplinary team, social work if there have been difficult family dynamics, occupational therapy to help people, as Dr. McDonough said, sometimes people who have overworked and have you know, have had to achieve throughout their lives and suddenly find that they can't work, or their working life has been reduced, and then they have, you know, not much else in their life. So, you know, doing a structured balance, also looking at social and leisure activities and self-care. So it is a very multidisciplinary approach that we take to address these issues.
Yeah, that's very good. I mean, I think CBT has a very strong evidence base for straightforward OCD presentations, but people need to be in a learning zone to do the CBT. So if their mood is overwhelmed, if their mood is depleted, it's going to be hard for them to learn from the behavioral experiments. The work's quite difficult. It's exposure and ritual prevention is the original name for the therapy. And now we use the Salkowskis model of cognitive therapy covered in the book Overcoming OCD. So if you can access a good, which is a little bit more cognitively focused and talks about the meaning attached to the thoughts and so on. So accessing a good cognitive behavioral therapist, either privately or through our services, would be step number one for those that are in a position to engage with the therapy. But some people aren't. Some people need mood restored and need maybe high dose venlafaxine or some antidepressant regimen to get them to a place. And then there are some people who present with OCD-like presentations who really need a deeper, longer-term psychotherapy, people with OCD mixed with maybe a perfectionistic and over-controlled personality who may have background traumas of different kinds that underpin the development of their condition. And they, you know, if they were within our service, we'd get a psychological assessment done and point them towards long-term therapy. But you can, as GPs, of course, refer people to the Humanistic and to the Irish Association of Humanistic and Integrative Psychotherapy website, which is different from the IACP website. These are people who are therapists who are geared up for longer term, more in-depth psychotherapy around developmental adversity. So it isn't a one size fits all. CBT is the go-to, mood restoration is key, but sometimes, as Anne has said, it's about a multidisciplinary effort or even a deeper psychological approach. And again, that's all built around assessing the individual and the presentation. I don't know if that answers the question, or is there a specific aspect of care that people are unsure of or would like to clarify?
We've no clarification at the moment of anybody, but if that comes in, we can circle back to it. But I know we were also wondering, and you have certainly mentioned some of them throughout, talking about some of the services that St. Patrick's delivers in the form of compassion-focused therapy, acceptance therapy, etc. But what anxiety therapies have the best outcomes in your experience?
Yeah, that's a good question. So you've got excellent responders, and then kind of more anxiety presentations with less good prognosis. So panic agoraphobia, panic disorder in its pure form, so-called Clarkian panic, as I would call it, where there's a catastrophic misinterpretation of bodily sensations, often associated with agoraphobia, fear of going out into crowded places or places where escape is difficult. That should respond pretty quickly to well-focused CBT. We get good outcomes for panic agoraphobia. However, sometimes you'll see presentations of panic that are actually post-traumatic. What the person is panicking about when they're out and about is a fear of attack, and that might relate to childhood abuse and complex trauma. So be careful about panic that doesn't fit the model, because often it's a more complex, in-depth case. Panic agoraphobia responds well. Next on the list would be straightforward OCD. OCD does tend to respond well to behavioral treatments. Now, OCD can be very complex and long-standing, and not every case is going to be that response. But your straightforward OCD presentation does tend to respond very well, as long as the mood component is managed. Then you've got health anxiety also responds really well, which is really OCD about health. All of you will have seen individuals with health anxiety who come back recurrently to your clinic. They do very well with CBT. Very good book, Overcoming Health Anxiety by Phelan Wilson. So they can do excellently well. Body dysmorphic disorder, which is OCD focus on appearance and defects in appearance, which can be difficult to separate from an eating disorder, but it does occur quite a bit. BDD, it's tricky often attending for cosmetic treatments and so on. Building insight and acceptance with individuals that presentation can be difficult. And again, there's a very good book, Overcoming Body Dysmorphic Disorder by David Phelan Wilson. They're a bit, that prognosis isn't so good, but if they're well engaged, they can do quite well, but a little bit more specialized though. So if you have a BDD case, it's probably worth referring them on for assessment, because they can be challenging. And then social anxiety can do excellently well if it's a very isolated social anxiety issue. If it's blended in with sort of generalized social anxiety or low self-esteem or mistrust schemas, that can be a bit more tricky, but social anxiety should respond quite well in its straightforward presentation. And then at the other end of the spectrum, you've got generalized anxiety disorder, which is excessive worry about uncertainty. That's a condition that can relapse a bit like recurrent depression. So maintenance antidepressants are often needed in GAD. And the CBT approach is quite good, but doesn't quite have the traction of the other disorders. So I'd refer people with GAD on to acceptance and commitment therapy, these sort of skills for living type stuff, to keep them out of the red zone, to keep them out of those depressive crises, and make sure they're on enough, if they do have recurrent depression, make sure they're on enough antidepressant to protect their mood. So that would be at the kind of worst end of the spectrum in terms of prognosis. But I think if handled well, they can do very well. So that'd be the kind of the spread of prognosis and responsivity, I think, across the disorders. I don't think I've missed anyone there, have I?
No. Just to say, GAD is generalized anxiety disorder. Just read a question just to clarify that. That's correct, isn't it?
That's correct, yes. And a quick word on post-traumatic stress disorder. Okay, so if single adult trauma, PTSD, in a functional individual responds really well to cognitive behavioral therapy. Very, very good outcomes can occur as long as the individual isn't too kind of carrying the burden of physical injuries or whatever, which obviously is a complicating factor. But so referral for CBT for adult onset PTSD is really important, and your general counsellor isn't necessarily equipped to treat PTSD. They're often very good at treating early life adversity and complex trauma and developmental trauma, but I would encourage referral for CBT for kind of straightforward adult onset PTSD.
We've had two comments slightly related to that around the idea that, the last year for many people has been traumatic. Separation from family, people hospitalized, people in the worst cases losing loved ones. the idea that there could be potentially more presentations of PTSD, and also somebody was just mentioning there about the idea that this, advice to wash hands, etc., that could lead maybe to an increase of OCD-like behaviors. How do people assess in surgery with somebody in front of them? Is this PTSD born out of the pandemic? Is this OCD born out of the pandemic? Or is this somebody who's in the in-between phase?
Yeah, I mean, PTSD is quite strictly diagnosed. So to diagnose PTSD, according to DSM or ICD-10, it needs to have been a life-threatening situation, either the individual themselves in a life-threatening situation or observing it in another person close by. So there may be genuine PTSD presentations over, situations where people have become very ill with COVID and their life has been at risk. But I would say the majority of presentations like that are adjustment disorders, adjusting to these circumstances rather than PTSD. Now, there may be a trauma component, so I'd be wary. I think it would require maybe a specialized assessment to kind of diagnose PTSD without there being a clear road traffic accident or a clear episode that's very circumscribed and clear. So I think, but if it's an adjustment disorder, if the person is overwhelmed, or if it looks like an adjustment difficulty to kind of adversity, and the person is very unwell and overwhelmed, it's likely that there's a depression in there somewhere. And I think going through the biological markers of depression, as Anne has done, is really important. We're not dismissing it as adjustment anxiety, and often the individual will bounce back and learn from it and cope quite well. So that would be the emphasis I would put on it.
Okay. We have another question here. It's related to adolescence, which we had sort of discussed earlier, is really more dealt with in Willow Grove. So you can send specific queries there, but it would be, I'm just going to put the question to you anyway, just for your view on it. Niamh was saying, have you any comment on the prevalence of anxiety among young people? Is it a normal phase of life that has become medicalized, or is it truly a pathological condition?
So I'm a little in the dark here. Anne might be able to comment better, but what I would say is that most anxiety disorders start in the teens, start in teenage years or childhood. So it is a disorder of childhood that sticks around in the adult and becomes a long-term disorder. So it's okay to have some obsessionality as a child, okay to have social anxiety and shyness, okay to worry a bit, as long as you grow out of it and don't use it as a way of coping in adulthood. So a big part of the psychodynamics of understanding adult anxiety disorder is looking at what has happened that has kept the person in this anxiety cycle into adulthood. Why haven't they moved away from it? So I think normalizing anxiety in childhood and adolescence, I think, is important if it's a natural response or developmental stage. But if it's clearly disordered, if there are ritualistic behaviors as a way of coping with adversity, if there's stuff that's clearly not helping the individual cope, has become a dysfunctional coping pattern, then I think clinical treatment is likely to be indicated. Do you have any? Well, first of all, the Willow Grove services, obviously, they're quite good at managing anxiety disorders, and they have some excellent therapists there. So they may be able to advise further, and referral into that service is certainly an option. But would you like to add anything to that? And did you do child and adolescent psychiatry?
No, I would agree with Dr. McDonough. I think that with anxiety, I'm sure that you as GPs would see a lot of things like school refusal, most often because of anxiety. And so again, when something is starting to interfere with what would be, kind of a normal everyday day-to-day life, which would be a child or a teenager being able to go to school and managing, any kind of difficulties that come up during the day, then I think those are times when to refer on, just as you would an adult. just to take a look and see where things might be coming from, especially if it is prolonged.
I'm conscious that the clock has beaten us, as we always knew it would. And I just, before we leave, I just wonder, you know, could you maybe, are there key takeaways that you want people to sort of bear in mind from the conversation that we've had over the last hour?
I think to keep doing it, keep doing a great job, because the referrals we get are very appropriate. There's lots of very wise referrals, very great work being done in primary care. I suppose for me, the crucial thing is to spot those enduring anxiety disorder cases. Don't be afraid to refer them on, because they often will do very well. And the evidence does support major burdens on people, hidden burden that can be alleviated. And also to focus very much on spotting mood depletion, agitated depression variants, and treat those if they're present. That's all primary care physicians, GPs are in the driving seat to start those treatments promptly and get great results. I often see people in the clinic who were in a crisis a few months back, and they are doing much, much better. And then we can start the work on the underlying anxiety disorder. So I think they're for me the two main messages, I think.
I'm going to really cheekily put a quick question, because it's just come in related to something there about advice on dosage for GAD, medication dosage. Just let me get the specifics of the question here if I can. The wording is, can you advise on med doses in GAD for GPs? I'm not sure if that's, I can imagine that's not something that can be answered quickly, but
well,
if there's even a point of information.
I mean, if somebody responds well to an SSRI, that's straightforward enough. You know, your 10 or your 15 or your 20 of escitalopram, or your 100 or 150 of sertraline. I think if you're stuck and you're not getting a response in GAD and worry, it's likely because there's the person's fluctuating in and out of agitated depression. They're having mood depletion because of whatever's going on in their lives. So their mood isn't sufficiently resourced. If that's the case, I would titrate up venlafaxine from 150 to 187.5 to 225 and maybe higher, because it's a noradrenergic antidepressant at higher doses, and that will often cover the depressive, the mood depletion that's occurring. So you'll see somebody with GAD struggling on 150, but move them up to 225, and suddenly they're spending 95% of the year free from agitation and low mood symptoms. And they obviously need to work on their worry tendencies, but at least they're free of the depressive component. So that's a very simple and important tip. I think many of you will be aware of it. Titrate up venlafaxine if you need to.
Well, glad we managed to squeeze it in. I'll just briefly, from the housekeeping perspective, remind you that the CPD points from the ICGP will be available to any of you that attended today, and you'll get those in. They'll be added in a couple of weeks. And there's a link in the chat box here that you can feed back on this webinar, which is actually really useful in terms of planning future events and future topics to discuss. So if you could take a minute to do that, that would be great. And as we mentioned earlier, all of the webinars from this series will be made available in the GP portal. So all of the stuff that we covered today, and I'm conscious there was a lot of it, you'll get the opportunity to watch back and go into specifics or follow on with any questions. And just to remind you, if you had anything specifically around adolescence, that email address to forward on a query is communications@stpatsmail.com. That's communications@stpatsmail.com, and they'll send on your query to the relevant people. So now at 12:03, we're not that bad. 3 minutes over is not that bad given all that we covered. Thank you, Dr. Michael McDonough. Thank you, Dr. Anne Rakpraja, and thank you all for being so great at engaging with good questions and indulging us in our polls. And enjoy your weekend, and thanks for your time.